All right, well, welcome back and good afternoon or maybe good morning, depending on which time zone you're in. My name is Amelie, and if you've listened to your videos, you've already met me, and it's good to be back with you. I just wish I was in person with you. And joining us today, in case you weren't with us yesterday, is Dr. Mimi Secor. Welcome back, Mimi.
Thank you, Dr. Amelie.
As our moderator, we have Dr. Kathy Ballridge. And Dr. Kathy Ballridge is a family nurse practitioner in Central Louisiana. And I know you've already met Mimi on the video. And I'll bet that you have some questions for her today because she had a really meaty content area with women's health. So I would like to go ahead and get started. I see some chats going on, and I'm just kind of waiting for a question, Dr. Kathy, when one comes to you. But I would encourage you, if you're a participant, to send us some questions because we want to make sure that we connect with you and that we're able to, to make sure that your questions are answered. This is a little bit of an unusual time and a little bit of an unusual format for most people who are taking a review course or a clinical update course. But we want to make sure that we reach out to you. So, Dr. Kathy, any questions for us?
We do. We have a question, Dr. Amelie.
All right.
Amanda asked, will we need to know the grades on heart murmurs? And if so, could you help walk us through how to determine the grade?
Okay, that's a good question. And I don't think they're going to say, is this a grade 1 or 2 murmur? But here's what I always tell people. When you put a stethoscope on a patient's chest and you hear a noise, and you think it's a murmur, the first thing that ought to happen is that your hand ought to fly to the chest right over the heart. Because if you can palpate a thrill, which means it's a grade 3 or higher, it automatically becomes a significant murmur. So your work is done in primary care. It means that patient has a significant murmur. They need more workup. Usually an echo is what we do. So again, I wish that NPs had a reflex that when your ears heard a murmur or a noise, that your hand automatically went to the patient's chest to feel for a thrill, because the feeling of a thrill, which the description of, it feels like the throat of a cat that is purring. If you feel that when you touch a chest, that's a significant murmur, and it always needs more investigation. So thanks for asking that question.
Thank you, Amanda. So you guys, do you need a reminder of the Q&A portion?
That's probably a good idea, Kathy. Let people know so they can be comfortable.
Make sure that you press the Q&A and ask your question so that we can ask it to Dr. Amelie and Dr. Mimi. You should have reviewed today cardiovascular, orthopedics, women's health, and maybe some men's health by this point in time in the day.
Yeah.
So if you have any questions about those, please, now's the time.
Okay. And the other thing, when we had our webinar yesterday afternoon, I don't know if everybody had a chance to watch the video yet of urology and STDs, or as Mimi says, STIs. And Mimi, could you just kind of talk a little bit about what they might be expected to know in the realm of STIs for their exam?
You have to make sure you look at your exam checklist, and that will give you the basic conditions that they're apt to ask you about. Obviously, chlamydia, gonorrhea, we usually test those two together. More and more questions on HIV and also on syphilis. Syphilis is on the increase. HIV is increasing in Hispanic men having sex with men. That's the highest increase in terms of a group. And also, you're going to want to make sure you review trichomonas. BV is a sexually associated infection that kind of likes to party with STIs, so you want to review BV. I always say what happens in Vegas doesn't stay in Vegas. When it comes to STIs, they're on worldwide tour. Yeah. Although I guess we're really curtailing that right now with Vegas shut down.
So, Dr. Mimi, when you talk about HIV, what about PrEP? Will they have any questions on the I
don't think so. Amelie, have you heard of any PrEP questions on the exam?
I really don't. I've not heard of that coming out yet.
Okay.
I think
It's not a bad idea to review pre-exposure and post-exposure. Pre-exposure prophylaxis is certainly on the increase. And looking at risk factors, some women might even qualify for PrEP. And certainly post-exposure, if you're seeing patients that have been sexually assaulted, part of your care of the sexual assault patient is to screen for and potentially treat for STIs, and also to offer potential post-exposure prophylaxis. So
yeah.
that's all covered really well in the guidelines. And if you don't have the CDC STI guidelines in your app or on the computer, you need to have ready access and review that information. We've added additional information after the urology lecture, so you can review some of those slides as well.
Yeah.
And I think it's really important to also remember that on the exam, because the questions are anywhere from what, 1.5 to 2 years old.
Yeah, good
When
point.
they get on the
Mimi.
exam, that you're not going to be asked late breaking changes. For example, with HIV, if the test is positive, you do a screening test and the test is positive, you're still going to answer Western blot. You're not going to see as a possible answer the new differentiation test. But in clinical practice, that's the test you're going to do. So you need to just know how to answer for the exam and how to answer in clinical practice a little bit.
Yeah.
So Dr. Mimi, speaking of guidelines, Megan asked, which guidelines are we going to be tested on? There are many conflicting guidelines. For example, ACOG, USPTF,
Right.
on frequency of cervical cancer screening.
Right. If there are multiple guidelines, you won't be asked any questions, basically. But there is consensus on when to start cervical cancer screening, for example. That is, at age 21, there are no exceptions for younger populations for screening. And also, these guidelines came out in 2012, and they're still contemporary. By age 30, we add HPV screening to the cervical cancer pap smear. And if both those tests are negative, then we repeat those tests in women 30 and over every 5 years. That's because the risk of cancer is so low in that 5-year period. It's not zero, but it's close to it. At age 65, you can stop screening. Or in 2018, they approved that you can continue. If you see someone, you see me, I'm 65, I'm planning to live to 110 if we get through this coronavirus situation. So I might opt to continue screening. Now, for young women, 21 to 30, you're going to just do the pap smear, the cervical cancer screening with a pap smear. And if that test is negative, then you're going to repeat every, how many years? 3 years. So you want to make sure those are clear in your brain for the exam. But I don't think if, for example, mammogram, there isn't going to be much on mammogram screening because
Correct.
there are huge controversies between the American Cancer Society and the United States Preventative Services Task Force. So just put an X through that slide.
Yeah. And you know, the questions that they ask you about on the exam have to be general consensus in the United States. So
Right.
especially when there's conflict among the big guidelines, it's always your clue that that's not going to be a question on the exam.
Right.
It's just, so anyway, that may make you feel just a little bit better.
And it's not a million conditions in terms of STIs. And you're going to want to just know the basic symptoms, basic diagnostic test, basic treatment.
Exactly.
I don't know if they're going to ask you about patient teaching, but I certainly always find that the app or the guidelines are great for that. You just can open them right with the patient and tell them you want to inform them, and meanwhile you're reviewing them yourself.
Good tip,
I do
Dr.
think
Mimi.
Very good tip. And I do think it is important that you differentiate in the question. Make sure that you read the question thoroughly, because there is a difference between screening tests and screening for risk factors. And so just be aware of that when you don't get hung up on the screening word and answer it and think that you've got it, because that'll trip you up. Make sure that you're determining what they're asking you.
Good
That
point.
is
And remember,
that's $1
Go ahead.
million tip, Kathy.
$1 million.
That's $1 million tip for the exam.
So Megan is on fire today. She has another
Okay,
question.
come on,
for us.
Megan, we're ready.
Men's
All right,
health.
Megan.
How
Men's
often are DRSs, digital rectal exams is what I think you mean there. Are
Okay.
how often are they actually performed? In almost a year of clinicals, I still haven't seen one in private practice. Can you diagnose prostatitis without one?
Can you diagnose prostatitis without one? I guess you could based on his symptomatology, but to be honest with you, digital rectal exams are falling more and more out of favor. And I think it is because there's so much inter-rater reliability issues. Some people find this, some people don't. There's a tremendous amount of inter-rater reliability. So because of that, the DRE is really kind of falling out of favor. And the other thing is that people hate to have it done. Men hate having that done. And so they usually look at you when you offer it as part of the exam, they'll say, no, I don't want to do that. And so, you know, I'm not surprised that you haven't seen it done. But anyway, there it is. So
I think that's funny, Amelie. We don't usually give women a choice when it comes to pap smears, and I don't know how many women absolutely love those.
yeah,
So,
of course
just
not.
as a, it's really not funny, but it is kind of funny. There was a bill that was introduced in Louisiana this year that says that medical students, are really any provider, they had multiple providers listed, cannot perform digital rectal exams or pap smears on a patient who cannot consent.
Oh,
That's
really?
obvious.
Yeah.
I understand that one.
So it was kind of interesting.
Yeah.
So it makes you wonder.
I'm sorry, Kathy.
That's okay. Go ahead.
I was going to say just in response to the previous question about could you diagnose acute prostatitis, you know, without a digital rectal exam? I certainly think you could, just based on symptomatology. And, you know, I think I mentioned in the video, my favorite question to ask a man when I suspect acute prostatitis is, did they have pain when they had a BM this morning? Because if you remember the proximity of the rectum and the prostate gland, if the prostate gland is enlarged and swollen, when stool comes down the rectum, it pushes on that tender prostate gland. So that's a pretty good clue for me. So anyway.
So outside of prostatitis, what other situations would you think a digital rectal exam is called for?
Well, certainly with a suspicion of prostate cancer. Because if you palpate, if you have an abnormal prostate exam, or sorry, digital rectal exam, and you palpate something hard, it always needs follow-up. And you'll be able to palpate, if you've never found one before, I can tell you exactly what it feels like. It feels like part of your finger that touches a prostate gland has a different feel. It's touching something with a different density or consistency in the tissue on a different part of your finger. And it'll be obvious that something there is not part of the original tissue. And, you know, I'm sure that I've missed them, but I also feel like I found a lot of them. And I remember finding the first one when I really didn't know what I was doing. And that's what struck me. So if you're not getting a lot of experience with DREs, you know, I'm sure that you don't feel real confident at picking up a prostate cancer. But I think when you touch it, you're going to realize that the tissue is not uniform in consistency. And that is always a big clue that something is probably in there and growing. So, so besides prostate cancer, you know, I don't know, that seems to be pretty valuable with a DRE and maybe acute prostatitis.
So we had one student that commented that that the clinical site that they were at, their preceptor likes to do them yearly. So would they see that on an exam?
No, absolutely not. And, you know, as I said, the DRE is falling out of clinical favor. And I just have not gotten feedback from students who've taken the course and who've taken the exam who've said, you know, they're getting a lot of those questions. I'm really not getting it. And I don't know if I mentioned this to you yesterday, but I get so many emails every single day from students who've taken this course and who've taken the exam, and I just am not getting a lot of questions on DRE. So maybe that makes you feel better.
So again, Megan, has a question about urology. She said, is there a specific number of white blood cells in a urinalysis that are diagnostic of a UTI? For example, more than 10, less than 10, etc.
Megan, thanks for asking the question. This was in your slide presentation that hopefully you viewed recently. And know that white blood cells, when they are present, usually indicate a urinary tract infection. It's very sensitive at 95%. What you're going to look for is greater than 10 per high-powered field on a spun sample. So that's kind of the parameter that you're going to keep in mind. But I highly doubt they're going to ask that on an exam question. Would you
I
ever
really
see that?
don't. No, I've never heard of that question, but I have heard of this one, and I think it's a really important one. The most sensitive indicator that a patient really has a UTI is the number of bacteria in the specimen. And that number is 100,000 or greater if it's a midstream clean catch. So
I was going to get to that, Amelie.
Oh, I'm sorry. I stole your thunder, Mimi. Go ahead.
It doesn't matter. But that is a number you want to keep in your brain. If it's 75,000 or 25,000 as an answer on a question, it's incorrect unless they're asking what numbers wouldn't indicate an infection. So thanks, Amelie.
Okay, I don't have any more questions in queue right now.
All right. I am
Megan,
go ahead,
I was
Megan.
just going to mention, Megan, and for everybody, remember that you're building the case for empirically treating for a UTI. So if you see white blood cells, if you, there are multiple indicators. And so the presence of nitrites, multiple indicators on the urine dipstick or the urinalysis may help you decide, okay, it's time for me to treat. Leukocyte esterase is an enzyme present sometimes that we'll see on urinalysis or urine dipstick. And so all these indicators you want to put together. Sometimes red blood cells, they alone by themselves may or may not indicate infection. So that's helpful to just keep in mind as you try to figure out, do I treat them, don't I?
Yeah, that's really good tips, Mimi. If nobody has any questions, I want to make sure that something I covered in the cardiovascular lecture is clear in your brain. And Kathy, do we have any questions in queue right now?
We did.
Actually, there's a good one.
Sure.
It's from Cynthia. She said, if you see cast in a UA, would you automatically refer for a higher level of care, even if not significantly symptomatic?
Really important question. The two types of casts you want to always think about as being abnormal, which was in the lecture. Hopefully you were concentrating, are white blood cells. White blood cell casts usually indicate pyelo. So really helpful indicator when they're present. You should immediately go to evaluating your patient for pyelonephritis. The other type of cast that's very important to be aware of and identify are red blood cell casts. Usually that indicates a pathology present. And you're always going to refer those patients to nephrology if possible, urology if that's all you have in your community, and then they can refer to nephrology from there. So those are the two types of casts. In your course guide is a chart of all the different kinds of casts, and that's nice to know, but really the need to know are the white blood cell casts and the red blood cell casts.
Yeah. You know what, Mimi, let me give people one step farther, and maybe it's my background in microbiology, but you know what a cast is? It's a protein globule. Okay, look at my fist. It's like a protein globule. And a red cell cast is a protein globule with a red cell in it. A white cell cast is a protein globule with a white cell in it. So protein never belongs in your urine, never ever. When it's there, it means there's some damage to the basement cell membranes. And so that's the only thing that can let out this big protein globule. Remember, proteins molecularly are very big. So if that's in your urine, you have a problem. And if it's coupled with the finding of red cells or white cells, that's very, very significant. That patient always needs some kind of referral. The only kind of casts that you should have no worries about are crystals. They usually have no particular clinical significance, and usually when you find them in the urine, it's a real red flag for patients that they need to begin to drink more and more fluid. But
yeah.
That's the only cast I'm not so worried about. Red cell and white cells always reflect pathology. So you did a great job on that, Dr. Mimi.
Thank you, Amelie.
All right.
So we have another urology question while we're there. If you
All right.
find hematuria while treating a patient with a UTI, you recommended follow-up during the lecture. What is the time frame for follow-up? Is there a specific number of red blood cells that are concerning? Is even a single red blood cell something to be worried about?
The basic follow-up should be probably within a month. If they meet the criteria for a high-risk individual, a male over 40 with any risk factors, then you're apt to make that referral sooner. So you always want to be looking, huh?
A smoker.
Smoker.
Sorry to interrupt you, but I'm clowning over
who's been
here.
in construction, who has been involved with the exposure to maybe asbestos. We always worry more about those individuals, but specifically you're going to be more concerned when there's greater than 25 red blood cells per high-powered field in a spun sample. And so that's specifically what you're going to be looking for. We don't always worry about a few red blood cells, but again, even if there's a few red blood cells, good care would dictate that you follow up within a month and make sure there are fewer, hopefully none. But that should guide you, and I'm just looking to see what slide that is in my presentation. 43 is the slide where that information on the red blood cells is present, and then the profile individuals we worry about are further into that slide presentation. So maybe just review those a little bit.
Okay, well, y'all know I'm a pathophysiology nerd, and I have a question for anybody who's listening. Do you know why there's blood in a urine specimen in a patient who has a UTI? Do you know why?
Because of inflammation.
It kind of helps you understand why you should follow up, but it also helps you understand why you see it so often. So look, here's what happens. If you listen to my antibiotics yesterday, what I said was that when a bacterium wakes up in the morning, it always has the same thought. Do you remember what that was? The thought of every bacterium when it wakes up in the morning is, I want to live another day.
Another day.
I'll do anything to live another day. So imagine a bladder, and it's got urine in it, and there are a lot of bacteria, and they're multiplying. They multiply every 2 to 3 minutes. When a woman or a man with a UTI goes to the bathroom, urine leaves, and bacteria exit the bladder. But they're always bacteria that are left behind in the bladder. So smart bacteria say, I want to live another day, and I like it in here because urine is my food source. So here's what smart bacteria do. Look, they latch on to the bladder wall. They latch on to the bladder wall. And when they latch on, they tell their friends to come up here too. Because when you go to the bathroom, they're on the wall and they won't leave. And they love being in your bladder. When enough of them congregate on the bladder wall, it causes erosion of the mucosa. And erosion of the mucosa causes shedding of red blood cells. So when you see a urinary tract infection and you see red cells, even though it's microscopic, it's understandable. It's because the bladder wall's mucosa has been damaged. But sometimes we see frank hematuria. You can see it, gross hematuria. Mm-hmm. So when you see red cells during a UTI, there's usually a normal reason for it. But we worry a lot after urinary tract infection is cleared if the blood hasn't. So,
and that's why you've got to follow up with anyone who has a UTI that has blood in their urine. You have to follow up. You can't drop the ball. Your number one question in a woman of reproductive age is to ask about menses. Even if it's a tail end of her period, like 7 days ago, her period started, she could still have blood in her urine. And like Amelie talks about, you don't want to make a referral to urology for menses. They're just going to wonder about you.
Yeah, and also, don't forget about drugs that can produce hematuria. Mm-hmm. Like NSAIDs are very common.
Yep.
Sometimes it's a patient who's on Coumadin or Effient or Pradaxa, one of the direct oral anticoagulants. So anyway.
Thanks, Amelie. When you created that image, I thought of a flash mob of bacteria in the bladder wall. That was really good.
That's exactly what happens. They love being in the bladder because there's an abundance of food and they want to hang around. And if they're smart, they got to figure out how to do it. And they latch onto the bladder wall.
And they have not heard about social distancing. Nope.
They've not. In fact, when cranberries were thought to be like, oh man, this is the bomb when it comes to urinary tract infections, if cranberries really did work, and you're from cranberry country, Dr. Mimi, But if cranberries really did work, you know how they worked? The mechanism of action, they made the bladder walls slippery. So when bacteria tried to latch on, they slid down the bladder wall and boom, urination.
Funny.
So, all right, that's probably more than you wanted to know right now, but
That's good, Amelie. Thank you.
all right, I
Very
want to
good.
help people remember it.
That's good.
So Cynthia asked, I know in the lecture you mentioned that an estimated GFR under 60 is quite common in older patients, but do they only need referral to nephrology if they have comorbidities, or do you refer when there's been a decrease even in healthy patients?
You make a referral if there's a decrease even in a healthy patient because there may be something going on. But you do want to make sure the number one cause for an abnormal estimated GFR is addressed. And what is that? Dehydration. So you want to make sure you've looked at that, you've corrected it before you make a referral. If they're trending lower, then you definitely need to make the referral. Amelie, anything you want to add to that?
You know, the only thing I would add is that nephrology does a fabulous job with patients whose kidneys are not functioning well, but they cannot bring a dead kidney back to life. So don't send them dead kidneys. And I'll tell you this, if the GFR is 50, you know, it's less than 60, but it's hanging in the 50 region, every one of those patients just about could get a normal GFR if you really get pouring fluids in them.
Absolutely.
Fluids are what make the GFR rise. The kidney is like a pump. It needs to be primed with fluids. And so, you know, the first thing you get a patient to do is drink 32 ounces with breakfast. Exactly, Mimi. 32 ounces with lunch.
I got it.
32 ounces with the evening meal. And you will watch, like, amazingly.
Do you know what that means to an older patient? Did you hear what she said? 32 ounces. An older patient like my mother at 90 thinks 8 ounces is a massive amount to drink in a day. So when she said that so kind of lightly, you just need to understand what that might mean to your patient.
But you know what else you have to tell them with the 32 ounces? You know, if you tell them 32, they'll probably drink 22. And 22 is better than none. But what you can tell them when they drink the water, tell them, listen, Miss Boudreau, you know all that constipation you've been having? If you drink this water, you're not going to have any problems with constipation. And they
that hasn't helped with my mother.
She's probably not drinking enough water, Mimi.
It's unbelievable.
Oh, okay.
So I know it's not showing any other questions in queue, but we did have one that was sent through email from a Phoenix student.
Okay.
She says, this is Beverly, for a AAA screening modality, which diagnostic is better for primary care, ultrasound or CT scan with contrast?
Well, it's always going to be the ultrasound. And the reason the ultrasound is the preferred test is because the ultrasound has the highest sensitivity and highest specificity, which means the most likely test to give you a true positive and a true negative. So, so the ultrasound is a preferred test. The other thing that's kind of an added bonus is that there's no radiation with an ultrasound. And so a CT scan obviously imparts a lot of radiation. So, you know, nobody needs that. And an ultrasound is certainly the preferred. And do you know how many? Once in a lifetime. And so it's a good way to pick up and save lives. It really is in people who have risk factors.
Absolutely. So Megan says she has a question that goes back to one of the lectures yesterday about GERD. Can you discuss the long-term use of PPI? When do benefits outweigh the risk? And what are the specific risks associated with the use of a PPI longer than 8 weeks?
Okay, those were a lot of questions. Start me with the first one, Kathy. What was the first question?
The first one is, can you discuss long-term use of a PPI? When do the benefits outweigh the risk?
Well, I would probably win the Nobel Prize if I could tell you when the risks outweigh the benefits. But, you know, generally when a PPI is given, its intent is 8 weeks at maximum. Because the FDA's indication for PPIs, proton pump inhibitors, is for most commonly to treat GERD. And all of the GI societies are in agreement when they say 8 weeks maximum with a PPI. So here's what happens. People take their PPI and their symptoms get way better, and they don't want to stop it, and they continue to be on the PPI. The issue with keeping these patients on it long term is multiple. But one of the worst is that, you know, the pH in the stomach changes for patients who have PPIs on board long term. There's certain things that you eat that you've got to have an acidic pH. And remember, the pH in the stomach is somewhere between 1 and 3. And when the pH rises because a patient has been on a PPI, especially long term, it inhibits their ability to absorb things like calcium and vitamin D and iron and vitamin B12 and folate and all sorts of things that you need for a healthy body over time. So we don't know how long is too long. And obviously there's some conditions in which you would never want to stop their PPI. If they had Barrett's esophagus, don't ever stop their PPI. If they have, you know, any type of chronic erosive condition, you would never stop the PPI. And of course, we use PPIs in conjunction with NSAIDs for people who are at high risk of GI bleeds. You wouldn't want to stop their PPI either. So the first thing you look for in a medical record, and this goes to a lot of older adults, the first thing you look for is a diagnosis associated with why that PPI ought to be continued. Because if you can't find a diagnosis in that, then the very next thing you ought to try to do is deprescribe that medication. And the word deprescribe means to try to decrease the amount that they're on that still keeps them symptom free, or to completely be able to wean them off of it. And, you know, some people you just have to realize are never going to be able to be weaned off their PPIs. And, you know, with those patients, you want to get them on the lowest dose of that PPI that they can tolerate. So I don't want to get hung up in how to deprescribe, but lowest dose for shortest period of time is probably a good rule with the PPIs.
And that was the second part of her question. What are the specific risks associated with the use of a PPI longer than 8 weeks? So I think you pretty much covered that.
Add one more thing. I'm sorry, Kathy. Let me add one more thing about the PPIs, and it is this. As the pH in your stomach changes, you're not able to absorb certain medications that you might take. And the one of them that I always think of is Augmentin. You know, we give Augmentin a lot. We give the cephalosporins often to patients who have infections. And those antibiotics are poorly absorbed in a less acidic environment. So you're not able to absorb as much Augmentin. So for somebody who's on a chronic PPI, in my brain, it makes me jump to a different medication to treat their infection with. That's far beyond the scope of your exam, but it just goes to show you how important an acidic pH in your stomach is.
Same with calcium, right, Amelie?
Oh, absolutely.
If you're taking a PPI, then really they should be taking calcium citrate for better
Exactly.
absorption.
So that's a good point. You know, there are two forms of calcium. The one that most people take because it's the least expensive form of calcium is calcium carbonate. That's what's in Tums, for example. But there's another form of calcium called calcium citrate. Chemically, it's a different moiety. And calcium citrate, which is under the brand name of Citracal, calcium citrate is able to be absorbed in a less acidic environment. So for you people who need to be on calcium supplementation, they ought to get it from the food. But if they have to be on a calcium supplement, calcium citrate is the one they should be on if they're on a PPI. Otherwise, you know, they're spending a lot of money on calcium citrate and spending money on calcium carbonate and not getting the benefit of it.
Yeah.
And it's just making them constipated too.
Oh man, thanks, Amelie.
We don't have any other questions in the queue at the moment.
Okay. When we had no questions a little bit earlier, I wanted to clarify something and make sure everybody got it from the cardiovascular section. And, you know, when I started off cardiovascular, I talked about 2 patients, and you had to decide whether or not you would give them an antihypertensive medication. And the stage of medications, the stage of hypertension that you should always focus on are the people who have stage 1 hypertension. Those are the people whose blood pressures are in the 130s over 80s, because that's the population where you have to use that risk calculator to determine whether or not lifestyle modifications are sufficient for them, or whether those stage 1 patients are people who ought to be put on an antihypertensive medicine. And so the way you determine that is to use that ASCVD risk calculator. You're going to use that in your clinical practice all the time. And you should treat that risk calculator as such a valuable tool of things you bring to clinic. It's as valuable as your stethoscope. So it's a free download, and you put in your patient's information, and it's going to tell you right there with the results from the app whether or not this stage 1 hypertensive patient, look, Mimi's got it.
Yeah, I got it in the upper right-hand corner.
And it tells you whether or not that stage 1 hypertension patient is someone who would profit from being on an antihypertensive med, or they would profit simply from lifestyle modifications. So I wanted to make sure we clarified that. And I think that the majority of questions you'll be asked about in cardiovascular, specifically hypertension, are going to be with blood pressure meds, because that's a big area for safety of questions.
Okay.
All right. Anything in the queue, Kathy?
Yep, one just popped up.
All right.
Mary says, in the video, you said to use pravastatin, so I was wondering if atorvastatin is wrong. I see atorvastatin or rosuvastatin being used only.
Okay. You know, a lot of people do that. And the real difference between atorvastatin and rosuvastatin and all the others is that atorvastatin and rosuvastatin are the highest potency statins. They have the potential in moderate to high doses of decreasing LDLs by more than 50%, which is very desirable for people who've got a history of an MI or a stroke, or people who have LDLs that are greater than 190. Those patients have the highest risk of an event, and we can decrease it significantly if we get them on a statin. And those are our 2 most potent statins. So that's why you see a lot of people using those so much, because we have so many diabetics who need a statin. And to be honest with you, those 2 statins also have an advantage, that they have the longest half-life. So, you know, you mentioned pravastatin. Pravastatin is a great statin. I love it. It's clean as a whistle. But its half-life is 1.8 hours, which means it's really important if you're on pravastatin to make sure that you take that statin at bedtime. Because as a human, you produce and synthesize cholesterol when you sleep, which is why it's so important to have a statin on board in close proximity to the time that it has to work. So if you're on a 1.8 hour half-life statin like pravastatin, you better be taking it at night. If you take it in the morning, the statin will be almost completely metabolized, and it doesn't have a chance to do its job. So a longer half-life statin like Crestor or Lipitor is a little friendlier for people who don't take it at nighttime. But I always recommend that people take their statin at bedtime. We just get better results. And you will too with your patients. And the last point, those 2 meds are generic. So you usually get a pretty good deal on them.
Yes.
The next question is just a general question. It says she doesn't have any questions right now, but she wants to know if she thinks of any more. Is it okay to send them via email?
She absolutely can. If you send them to questions, I'll pick them up. And I'm sure Nina is cringing right now, because Nina helps me get organized and with my schedule. And but we want to make sure that you feel like you've gotten your questions answered. So if you have something, you can send it via email. And if it, you know, if the email gets to be overwhelming, we'll figure something out. But I want your questions to be answered. The reason Kathy and Mimi and I are here today live to give you an opportunity to ask a question is because we want you to be successful. We want to make sure that you're successful on the certification exam. So feel free, I should say.
Feel free.
Anything else, Kathy?
No other questions at the moment. Nothing I see in the chat.
So what are people chatting about? Do you find this helpful? If you're chatting, I would really like to find out if you think this has been helpful.
I don't see anything there, but.
So can you guys let us know? Beverly said this is very helpful.
Okay.
I have a reminder to clinicians who are soon to be nurse practitioners.
Go, Mimi.
You are going to be under great pressure to treat patients by telephone for both urinary tract infections and vaginal infections.
Mm-hmm.
And I am just going to beg you, and this is really straight from the CDC, to get these patients in. Try not to treat patients over the phone. Not really even worth triaging much by telephone. I know we're in a unique situation now, but when you get patients in with urinary tract infection symptoms, you may find they have vaginitis. You may see patients with vaginitis and it may turn out they have a UTI or maybe both, especially if they have bacterial vaginosis. There is an increased risk for UTIs with patients that have bacterial vaginosis. In patients that are postmenopausal, there's an increased risk for UTIs, especially if they're not using any kind of estrogen, systemic or local. So don't take the bait when patients call and say, I have exactly the same symptoms I had before. I just know I need a prescription. Don't take the bait. Make sure they can come in and that you have a flexible schedule to be able to get them in. And again, right now may not be a good example. You may feel like you have to, your whole practice needs to be virtual right now. But when everything settles down, be really careful about that.
Yeah. Oh, that is such sage advice. And you know, Mimi has been in practice for more than 40 years as a nurse practitioner. I mean, that's like unbelievable. And when Mimi says something, because it's from her wealth of clinical knowledge, Mimi, I think, and I hear your voice in my head so many times.
And I've done a lot of triage work. So I know the pitfalls.
But that is such sage advice, regardless of whether you're starting your practice or you've been in practice for 25 years. So
well, we just want to help you, like Amelie says.
So we do have a couple of more questions.
Okay, sure.
Latif says, can you discuss about orthopedic expectations and ortho medications?
Orthopedic expectations. You know what, this is what I usually tell people. You should learn how to assess and diagnose and treat the 25 or 20 most common orthopedic diagnoses. These are the things that people are coming in with all the time. They're coming in with strains, they're coming in with bursitis, tendonitis, and they're coming in with back pain and, you know, hand things. But look up the 20 most common orthopedic diagnoses and make sure that you know how to assess those patients and how to diagnose them. Don't get overwhelmed with the 10,000 orthopedic tests that are there. And so when you go into your practice as a brand new NP, if you can treat the 20 most common orthopedic ailments, then add to your repertoire of testing of 10 every year. By the time you've been in practice for 10 years, you're going to be an ortho expert. You don't have to be an expert right now, but come in with a knowledge base that'll get you through the most common types of patients. And
I always think of what you say, Amelie, when you talk about replicating the pain. If you can replicate the pain in the clinical scenario, then it's more likely to be ortho. But if you can't, it's less likely.
Oh, yeah.
That's great advice.
Yeah, you have to rebuild your differential. If it's orthopedic and you can't reproduce somebody's pain, that's a huge red flag for me.
I always think shoulder pain, man, if you can't reproduce it, you got to be thinking cardiac, right?
Cardiac or even neck pain.
Yeah, exactly.
Yeah.
Exactly.
So that's my best advice. And the second part of the question, I think, dealt with orthopedic medications. Mm-hmm. Well, they kind of fall into three groups for the most part. There's acetaminophen, which, you know, some people derive benefit from, but most people don't. The biggest group of medications I think of with orthopedics are the NSAIDs, the non-steroidal anti-inflammatories. Those happen to be some of the most commonly purchased medications over the counter and some of the most commonly prescribed. So with the NSAIDs, there are some real big places you have to watch. One of them is GI issues. The second you have to really watch out for are cardiac issues. And I think in the video I told you about a COX-2 inhibitor, which is an NSAID that's gentle on the stomach, a COX-2 inhibitor called Vioxx, and another one called Bextra, which were removed from the market because they increase the risk of MIs in patients who weren't even at increased risk of MIs. So when you give an NSAID to a patient, you always got to do a really good cardiac screen because, you know, if they've had an MI, the American College of Cardiology says that patient should never get another NSAID. So watch out. And then the third place, GI, cardiac, and the other big place we watch for with NSAIDs are the kidneys. You know, nobody dies of their osteoarthritis pain, but you can die pretty fast of a GI bleed.
Mm-hmm.
You can die pretty fast of renal failure, and you can die pretty fast of an MI. So you want to try to treat their pain with an NSAID, but you really have to screen and be careful about the patient and whom you give it. So acetaminophen, the NSAIDs, and the third class of meds that we use a lot in orthopedics are the steroids, right? Because they're potent anti-inflammatory agents. And they really work pretty well if the patient has an overuse injury that's created an inflammatory condition, like a tendinitis, a bursitis. And of course, NSAIDs can be taken by mouth or by joint injections. So hopefully that helps with the meds.
Yeah, Beverly, to expand on that a little bit, Beverly asked, how about meloxicam for arthritis? Is it safe as a COX-2?
Well, I'll tell you, meloxicam is not really a COX-2 inhibitor. You know, the cyclooxygenase pathway that we use to help get rid of prostaglandins, and that same pathway is what creates pain. You know, prostaglandins maintain homeostasis, but they also cause pain. So we have COX-1s, that pathway, and we have the COX-2 pathway. The COX-2s, the true COX-2s, are really only Celebrex. Meloxicam is not a COX-1 and it's not a COX-2. I call it, but nobody else does, a COX-1.5. It has properties of a 1, and it has the GI properties of a 2, but it really doesn't belong to either one, and it's much more like a COX-1 than a COX-2. It also is on the $4 list, so which it makes it less expensive than Celebrex. So I do like meloxicam, but I don't like NSAIDs in general, just because people don't usually die from tendinitis or arthritis or bursitis, but they sure can die of those 3 ailments that NSAIDs have the potential to affect.
My dad did. GI bleed, complications from a GI bleed in a nursing home on NSAIDs.
Yeah, it happens every day in this country. There are people who die of GI bleeds.
Crazy.
I mean, it's just striking. It's shocking when you think about it. And NSAIDs are often a big cause of it. So
if you have a patient who is on one of those and they have risk factors and Tylenol isn't working, what would be the next recommendation?
I guess if it was not osteoarthritis, because osteoarthritis is a chronic condition, and you know, you really are not supposed to treat those patients. The latest guidelines shouldn't treat those patients unless they're very symptomatic, but that shouldn't be every day. I like topical modalities. Heat, exercise is good no matter what you have, unless it's unstable angina. Exercise is good for everything, and that's the mainstay of therapy is non-pharmacologic management of something like osteoarthritis.
How about CBD?
What's that? Oh,
How about
CBD.
CBD?
I'm sure you won't see it on your exam.
You can slather on it.
All of the information with regard to cannabidiol, which is CBD, is anecdotal, which means it's a report from somebody else. CBD has been in the news just recently because the Arthritis Society, now not a medical group, but the Arthritis Society has published that CBD oil was helpful anecdotally. And for some people it helps. I've heard I have a patient, a lady with rheumatoid arthritis who swears by CBD oil. But, you know, it's not cheap. And so, you know, if it helps, if rubbing a tea bag on you helps, then, you know, go ahead and do it. It's all about trying to get patients pain relieved. But I really,
But it is,
go ahead, Kathy.
I was going to say, it is important to talk about the non-pharmacological modalities, especially when it's joint pain or knee pain. And those are not popular topics to have discussions with patients about, but you know, a lot of times we've exceeded our weight limit on those joints.
Yep.
And so reducing the weight is helpful. Reducing the amount of inflammatory foods in your diet, making sure that you're drinking enough water. All of those things are very, very important, especially if, and NSAIDs, like she said, if you take them for a long period of time, you're going to have some complications anyway. And so we need to be doing that education up front with patients as well.
Yeah,
that's good, Kathy.
That's great, Kathy.
Yeah.
Oh yeah, that was good.
Even massage, swimming, acupuncture, I mean, all those modalities.
Yeah, good. The people who are on this, I want you to know that you are getting the benefit of about 100 NP years worth of experience with this chat.
And we're all still so strong and healthy.
So anyway, what about another question, Kathy?
So Megan says, do you anticipate that we will be able to take national certification tests, AANP or ANCC, in the next few months? I'm worried because all the ANCC testing centers in the U.S. have closed for at least a month.
Yes, I absolutely believe that you'll be able to take this exam in the next, your comment said several months. I'm confident of that. I know that the testing centers have closed because they don't want multiple people in one area. And so in the next, I would say, you know, I don't know. I mean, I'm listening to the same thing you're listening to on TV. July or August, it should be, you know, in a way better place. And I'm hopeful that it is so. And that's why I think you made a valuable choice when you picked the hybrid course, because you can listen to everything right now. You can go through all the areas and identify your weaknesses. You can go learn about it. And as you get closer to the time where you're going to take your exam, you can use your second viewing to run through this content again. That would be a very valuable study strategy. And I mean, I think you made a really good choice with the hybrid selection. I really do. So.
So this says my exam is supposed to be April the 3rd. Do you think I will be able to take it?
I'm going to be honest, because I'm just going to keep this real. I think April 3rd, the testing centers will still be closed. I really do. I got an email from somebody yesterday who said she had passed and it was earlier this week. And I think the testing centers allowed people to take the test if it had already been scheduled. But I think April 3rd is going to be too soon. Obviously, I'm not in charge of the testing center.
Oh, yeah.
And I know they won't let you take it remotely. So, you know, that's not going to happen. I would imagine, you know, early summer maybe. I hate to even say it like that, but we have to get a good grasp and grip on the spread of this virus, or it is going to wipe out an entire generation. Your grandparents, your parents, and you know, we have to get a grip on the spread of this virus. And we can't do that when people congregate in one place. And that's what happens in a testing center. So, you know, I don't know. Use this time to study and really beef up your knowledge. Just continue to go through it. Quiz yourself every day so that this information is always top of mind for you. And you'll see that when you go in to take that exam, you're going to be confident. And confidence is always good for several points. I know that it is when you take your exam.
That's a therapeutic quarantine, Amelie. Forced study.
We have no further questions.
What time is it? It's 5 minutes to 2 in Central Standard Time.
Wow, time flies.
Yeah. You know, I just saw a comment come up about the topical NSAIDs. You
Yes.
might know that the FDA, before they got really busy 2 weeks ago, the FDA approved a topical NSAID for over-the-counter use. Did you hear it? Topical NSAID for over-the-counter use. So you're going to see people using that. But I want to make sure you know, while it seems like that's a much safer NSAID, and I really believe it is, it carries the same black box warning as an oral NSAID for GI bleeds. So just be careful.
The $1 million question is how much is absorbed? What are the blood levels?
Well, you know what? More than that, it depends on which joint you use it on. So if you use it on a bony prominence like an elbow, the chance of absorption of that NSAID is going to be way greater than if you use it on a hip. A hip has more flesh on it, and you have to imagine absorption of that NSAID into the area. So what I worry about is people using it topically and taking it orally at the same time.
Oof.
That's when you're going to see renal failure, cardiac issues, and GI bleeds. So that's just what I'm thinking about today.
Well, we always learn from you, Amelie and Kathy.
Let's see.
Thank you, Dr. Mimi.
Somebody's
sorry
going on.
about this. There it goes. So what I am thinking is that it's about 4 minutes to 2, and if there are no other questions, I would say let's wrap this session up, and I would say I'll see you this evening with everybody. So hopefully you'll go back and listen to more of your videos, and we're waiting to see you again this evening. Y'all have a good afternoon. Thank you for joining us. Thanks, everybody.
Thank you, everybody. Have a great day.